How are you sleeping? Are you sleeping? I'm Dr. Shelby Harris, Director of Sleep Health at Sleepopolis, and this is Sleep Talkin' with Dr. Shelby, the show that dives deep into all things sleep so you can get the rest you deserve. Today, we're learning about how to treat insomnia with Dr. Michael Grandner. Welcome back, listeners, to part 2 of our 2-part special on treatments for insomnia with Dr. Michael Grandner. Last time in part 1, we discussed cognitive behavior therapy for insomnia, or CBTI, as a possible solution. If you haven't listened to that episode yet, make sure to check it out. It's a really great deep dive. This week, we're diving more into other options, including acceptance and commitment therapy for insomnia, as well as typical insomnia medications and how they work and when they might be indicated. Insomnia is a condition that makes it difficult to fall asleep or stay asleep, even in ideal conditions. According to the American Psychiatric Association, 1/3 of all adults experiences insomnia symptoms. It is that prevalent. More recently, ACT, acceptance and commitment therapy for insomnia, has gained popularity, and there's some interesting research behind it. Even though there's extremely well-researched treatments for insomnia out there, a lot of confusion exists about just where to start, both for patients and many doctors alike. I hear the confusion all the time. That's why we've invited my colleague, Dr. Michael Grandner, to do a deep dive into the different options. Among many other distinctions, Michael is the director of the Sleep and Health Research Program at the University of Arizona and director of the Behavioral Sleep Medicine Clinic at the Banner University Medical Center. Michael, thanks so much for being here for our special 2-part episode, and welcome to Sleep Talkin' with Dr. Shelby. Talk to me about ACT therapy for insomnia, so acceptance and commitment therapy. So how did that come about?
Yeah, ACT is kind of new. When I was in training, I didn't get it in grad school until I was on an internship.
Yeah.
And then, and my supervisor was like, okay, I'm going to teach you how to do this stuff with ACT. I'm like, well, what's ACT? It's acceptance and commitment therapy. I'm like, well, what do you do? And then she's like, you know how in CBT, where the goal is to change their thoughts and feelings and behaviors, right? I'm like, yeah, that's therapy. That's fixing a problem, right? That's what you're paying for. They're like, okay, well, in ACT, we don't change anything. And I said, but what do you do then? Like, I can change nothing for free. Why do I have to? Why would I pay a therapist to not change anything?
It's such a foreign
and she's
concept.
like, and so she explained it to me. And it's a total paradigm shift in terms of thinking about this. And broadly, what acceptance and commitment therapy is, the way it's not changing things, it's changing how it's accepting a situation and committing to sort of doing what you can do around it. And so an example that I really like, and the way I learned it, was with chronic pain. The chronic pain makes perfect sense to me from an ACT perspective, because so when someone would come in with chronic pain, when we'd be taking an ACT perspective, I'd say, okay, what is your big issue? My pain. Okay, what's your goal? To get rid of my pain. Why? So I can live my life. All right. Can't live your life in pain. No. Okay. So what have you done to get rid of your pain? Everything. Okay, have you tried this? Yes, all the medications, all the shots, all the therapies, all the physical therapy. Okay, still in pain? Yes. Okay, now what? Okay, so you've maybe eliminating your pain by treating it and getting rid of it, maybe that's not a workable goal. Maybe your perspective that I will live my life once my pain is all gone is not the goal, because it's never going to happen. So what are you going to do? Just spontaneously combust? Your life is over? I mean, if you were in a wheelchair and you said, well, I'm going to live my life. I can't walk. I can't do anything if I can't walk. I can't go anywhere. I'm non-functional. Until I can walk again, my whole life is on hold.
Yep.
That's not realistic. You're going to have to figure out a way to reorient your life.
Yeah.
And Um, and with sleep, it's not quite as extreme as that, but sleep was never meant, not meant, who knows. Sleep doesn't need to be perfect to be functional. And a lot of people will wake up during the night. Some people with pain, people with medical conditions, maybe making yourself, people say, I want to sleep like a baby. Anyone who says that has never had children. No one wants to sleep like a baby.
No.
But what they mean is they want to sleep like, you know, an adolescent. That's what they mean, right? And maybe you're not going to be able to do that.
Yeah.
Okay. Maybe you're going to wake up a few times during the night. Maybe you're going to have an awakening in the middle of the night at 3:00 in the morning that is unavoidable. And then you're not going to be able to get back to sleep for at least an hour or two. Okay. Now what? What are you going to do?
Yep.
What do you do with that information? Or maybe you've got sleep apnea and you're going to have to wear a mask for the rest of your life whenever you go to sleep, or else your sleep is going to be shallow and non-restorative and you're not going to be able to breathe. Maybe that's what you're going to live with. Okay. Now, what do we do with that? How do we help you accept that maybe this is the reality and navigate around it? Rather than, instead of moving the boulder out of the road, what if the boulder is unmovable? How do we build a new road? How do we build the road around the boulder rather than trying to move it? That's acceptance and commitment therapy. And so how does that apply to sleep? And so what you do is you figure out, what do people want? Like when they say, my life is on hold, I'm not going to live my life till this is fixed. What does that mean? Who are you? Who do you want to be? What do you want to do? What is important to you in your life? What, if I checked all these boxes, your life would be complete enough to be satisfying. What are those boxes for you? Does it have to do with being a parent, being a family member, a child, but mean your job, your work? Does it mean your hobbies? Does it mean being active? Does it mean like learning? Does it mean exploring and travel? What are the things in your life that give your life meaning? And then how do you live according to those values?
Yeah.
While also having sleep issues. Maybe, we can get your sleep as good as we can get it. But for some people, some people with medical conditions or something, they're going to have awakenings during the night. They're going to be a little more tired during the day. Maybe there isn't a way around that. Okay, how do you live your life with that? How do you make it so you're not making it worse? So like often what happens, for example, is someone wakes up in the middle of the night because they have some sort of flare-up, whether it's pain, inflammation, stress, who knows? They get this flare-up, and then it has to settle back down.
Yes.
The analogy that I like is a snow globe, where something shakes up your snow globe, and you're awake. Whatever the shaking happened before you woke up, you may not even know what it was, but now you can't get back to sleep again until the snow settles. And the key here is you cannot make it go any faster. There's nothing you can do to make it go faster. You can make it go slower by continuing to poke it, but you can't make it go faster. And
I love that.
And stimulus control would say, okay, well, if you're not going to sleep anyway, get out of bed until your snow settles back down and then get back into bed, fall back asleep. It's fine. But what happens is the flare up happens and the snow starts settling. But right about here, people start getting frustrated and then they start getting stressed. And so by the time that snow has settled, now they're dealing with another issue. And sometimes stimulus control helps with this. Sometimes it's ACT. Sometimes it's like when you have that experience of the snow globe getting shaken up, if it's predictably going to happen, worrying about it, fearing it, trying to fight it, actually is just going to make it worse because now you've got this second issue you need to deal with. You got to wait for that to settle, and you're spending more time awake than if you didn't need to worry about it. So sometimes changing your perspective on things. Sometimes it's about scheduling. Sometimes it's about, what is it that I need to do? Do I have to sleep all in this one compressed time? Maybe we need to split sleep up a little bit with some people. Maybe we have to schedule stuff in their day at different times. And it's about accepting that, look, my sleep isn't going to be perfect. But then you have to commit to doing what you need to do to navigate around that and still live your life.
But I like that you say maybe accepting that your sleep won't be perfect and then working around it, because a lot of people, the problem with ACT, or especially acceptance, they think that you have to learn to like it
Right.
for the
No, no,
acceptance. You don't. You just have to
no.
deal with it. That's it.
Right. And it's a limitation you have.
Yep.
If you had PTSD, you would have a limitation around your sleep. You have hypervigilance issues. It'll be hard to wind down.
Yeah.
The bed may be a stressful place, and it may always be. Now what? Okay, if you had no legs, you would have a limitation where you'd be in a wheelchair. If you were blind, you would have a limitation where you couldn't see. You'd still have to live your life. Find a way to live your life with it. This is just a limitation. Everyone has limitations. It's not just you. Everyone has whatever limitations they have, whether they're emotional, social, physical, biological, chemical, structural, financial. Life is defined by our limitations. But we can't let those limitations prevent us from being who we are. And sometimes we get so caught up in the limitation, we forget that there's other paths to the destination we're trying to get to.
So what about the research then for ACT? I mean, it is newer, much newer than CBTI.
Yeah, and ACT is sometimes harder to study, but there are a few studies already on ACT and insomnia, especially when people have sleep issues. Especially when people have sleep issues that are maybe more complicated, or where maybe they've tried CBTI and that's, they weren't able to reprogram their sleep because of whatever that limitation happened to be. There are a few studies now looking at ACT, and it seems to work shockingly well.
Yeah.
It's just like surprising, like better than people would have even anticipated.
I was surprised.
For sleep.
Yeah.
And really, once you see it in action, it makes more sense. Because especially, I mean, in the real world, when I use it in clinic, it's often in combination. Sometimes we do sort of the CBT up to the point where we hit a wall, and it's like, actually, maybe plowing through the wall wasn't the option. Maybe we need to find ways around it. Or maybe the sleep issues you have to do with this mismatch between sort of what your goals are and what you're trying to achieve. And maybe we need to reorient you a little bit. Maybe we need to focus on some of the positive stuff. But yeah, the data on it, there's not a lot yet, but what's there is surprisingly good.
So what would make someone go for, say, ACT over CBTI or vice versa if they're not sure where to start?
Good question. My personal opinion would be that in most cases, I'd start with CBTI because it's more of, it's sort of like, well, let's teach you the skills and see how far they take you. But that's because I'm more of a CBTI is my home. But if I was thinking about this more conceptually, I think ACT would come into play in a situation where it's not where making a change to your ability to sleep is less feasible. Where, if your sleep issue is, or where your complaint is about sort of the complaint about sleep, where maybe it's like, especially if you're like, I feel like my sleep should be better.
Yeah.
Well, maybe it's the should that's the problem. Where it's might not be about the details. Maybe it's just like this general perception that your sleep is bad, but you can't really figure out why. You're just unhappy with it. Well, maybe that's the problem. Maybe the problem is just that you're unhappy with it. What's interesting is, so we did this study a couple of years ago where we looked at 1,000 people in the community and asked them a whole bunch of questions. They weren't selected for sleep problems, but a lot of them had sleep issues. And we gave them the ISI, which is Insomnia Severity Index. And anyone can Google it. You could take it yourself. And what's very obvious about the ISI is that there's actually it's 7 questions. 3 of them are the sleep questions. I have trouble falling asleep. I have trouble staying asleep. I might sleep fine, but I wake up and I can't get back to sleep. The 3 sleep questions. There's 2 questions that address daytime complaints, like it's interfering with my ability to function and it's noticeable. It's daytime function. But then there's 2 questions that are about your perception of your sleep. It's I'm dissatisfied and
Yeah.
I'm worried about it. You can say I'm dissatisfied and worried, fall asleep in 5 minutes, sleep for 8 hours in a row,
Yeah.
but wake up and have no daytime impairments and still be dissatisfied for some reason. So like I sort of call those perception symptoms that are independent of daytime and nighttime.
Totally.
And when we looked at mental health, what we showed was those perception symptoms and the daytime symptoms were the ones that were the most correlated with the mental health symptoms, where it wasn't necessarily about whether or not you can sleep at night. It was actually, do you feel like it's impacting your ability to function during the day?
Yep.
And it wasn't even about whether or not it's impacting your functioning. It's does it feel like it's impacting? Or do you feel dissatisfied? And actually maybe, so in that case, maybe that should have been the target all along. And I have to give credit. There's a researcher, Jane G. She was from Hong Kong, and she came to the U.S., spent some time in Canada as well. And she had developed, while she was in Hong Kong, she developed a culturally tailored insomnia intervention that involved a lot of actually there was some of the CBTI components, but there was a lot of mind, body, spirit stuff during the day. And what she had found was, she published this in Sleep Medicine, she found that not only did it work for insomnia, but it had profound impact on people's mental health during the day. And when I spoke to her about it, that was one of the things that she really noticed was it was actually about helping people, no matter what's happening at night, helping people navigate their daytime, because that's what people really cared
100%.
about. And that really helped me focus this question. And I agree. So if the problem really may or may not be what you're doing at night, it's just how you're feeling during the day. And maybe you're attributing that to your nighttime, because that's the other thing too, that a lot of times we'll have people say, well, I'm feeling kind of fatigued during the day. I think it's because of my sleep. Then we fix their sleep. They're sleeping fine. They're still feeling a little kind of fatigued during the day. Well, maybe it's because of some medication they're taking, but maybe there's no way around it. Or maybe it's because of something else.
I love a pie chart. I'm always drawing a pie chart. What are all the reasons why one could be fatigued during the day, right?
Right.
So it's not, sleep's a piece, but it's not the entire piece all the time.
And maybe ACT is about changing those perception issues.
Yes.
If the perception is what's stressing you out, maybe learning to accept it and still being fine is maybe a very powerful thing.
I love that. And that's why I think the trackers for sleep are a double-edged sword. So they can be a great thing, but exactly. But if it's making your perception worse about how you feel during the day, then you might want to get rid of them. Right.
I mean, it's so credit to Amy Athey, who's another great psychologist who came up with this concept that I love, is a bathroom scale is not a weight loss program. And sleep trackers are like that bathroom scale. They can give you information, but sometimes that information isn't helpful. And it's actually might be causing more stress than it's solving. It's more about what you do with that information. That is what makes it useful.
I love it. So briefly, what about medication? So what medications do you see prescribed a lot? And like, when would someone want to potentially or need to potentially go on that route?
Yeah. And obviously, full disclosure, we're not physicians. And so I'm not changing anyone's prescriptions. But I mean, we see it all the time.
Yeah.
So I'll just never forget. I had a trainee once who was a psychiatrist, and I was going over the AASM's prescription medication recommendations, which are generally good recommendations. And I'll never forget. She's like, "Oh, that's the document that says don't use all the thing my psychiatry training told me to use for sleep, and the thing that says to prescribe all the things we're told not to prescribe." And I'm like, "Yeah, that's pretty much where a lot of medications that are being used." So a lot of people would be surprised to hear that, trazodone doesn't beat placebo. On average, it doesn't add any time to your sleep. It doesn't make you fall asleep any faster, stay awake during the night any less. Except patients say it does. So this is the paradox.
Interesting.
That it's prescribed. It's not a controlled substance, so it's easier to prescribe. It's cheap, and patients say they like it. And for a prescriber who doesn't know any better, it's probably fine.
Yeah.
It may work actually. No one knows why patients say they really like it, because all the evidence shows that it shouldn't work. So why does it?
Yeah.
My pet hypothesis is that it has a slightly sedative effect. So
Yeah.
people feel like it's working, even though it's not actually doing anything. It feels like something's happening, which
Yeah.
gives people permission to sort of let go and be like, ah, I took the thing, it's going to work. So it really might be a placebo, but people don't think of it as a placebo.
Yeah.
So maybe it's that effect. Who knows? Maybe it is doing something we just don't understand. But it doesn't. But it's used a lot, and but then it doesn't work for a lot of people, and then they get
Yeah.
discouraged.
Yeah.
So there's other, most medications out there that for sleep, they work by boosting GABA in the brain, which makes sense because GABA is the main neurotransmitter that drives sleep drive. So if you want to turn the volume up on your sleep, boost GABA. The only problem is the more you boost GABA, the more side effects you have that you don't want. Things like falls and cognitive problems and memory issues and slowed reaction time and daytime grogginess and tiredness that make the daytime miserable.
Yeah.
So, but for some people they work great.
Yeah.
The safety data on them long term, just to be totally honest, just really aren't that great. And it has to become a cost benefit thing that you're dealing with your doctor. And that includes the older medications, the anti-anxiety medications that often are prescribed for people with sleep issues who have anxiety issues that don't seem to work great for sleep, or sleep-related medications. But then you have what are called the Z drugs. So this is zolpidem, zopiclone, and Zaloplan. And in the US, zopiclone is S-zopiclone because it's a different format of it. They're not quite the same. They work on the same receptors as the older medications with sort of more side effects, but they seem to be a little bit safer.
Yeah.
But they still work in the same way, and they still have some of the same issues and problems. But they're for short-term use. I don't know that they're that it's maybe that's what they're best for, but a lot of people are taking them long term, and that's where you get some
so
of these
rare
negative
that it's
effects.
short term.
Yeah. So then you have another group of drugs that are being used.
Wow.
are drugs that essentially hit on histamine. There's Benadryl is sort of the most common.
Yeah.
But even, part of the main reason the trazodone seems to be sedating is through the histamine system. You have doxepin, and you have some of these others that are working through histamine. So histamine is a neurotransmitter that I'm continually surprised how shockingly little we understand histamine as a neurotransmitter. For our seminar, like we have this weekly seminar on Thursdays, 9 a.m., free to everybody. But it's probably not interesting unless you're a researcher or a clinician in sleep. But for the life of me, cannot find an expert to come on and talk about histamine because there doesn't seem to be one.
So interesting.
We understand it shockingly little, except we know that it promotes alertness, and blocking it blocks alertness.
Yep.
And so that's why things like over-the-counter stuff like Benadryl, it's relatively safe, but again, long-term, it actually seems to backfire, wears off over time, causes memory problems and other risks, may not be good long-term. And the prescription medications might be a little cleaner in terms of how it's dealing with some of the histamine effects. But again, that's why it doesn't work for everybody.
Yeah.
And a lot of medications that are used is because of the histamine.
And then there's the newer ones.
And then there's the newer ones. So the newer medications, the dual orexin receptor antagonists, or DORAs. So the way DORAs work is totally different.
It's fascinating.
Where they block a neurotransmitter called orexin. Most people have not heard of orexin. They've heard of dopamine and serotonin and stuff, but they haven't heard of orexin. Orexin was discovered about 25 years ago. We still know shockingly little about it. It's a whole neurotransmitter system in the brain we know very little about, except one of the things it seems to be really important for is stabilizing wakefulness. Mm-hmm. It doesn't mean it's not really a stimulant. It doesn't really wake you up like caffeine does, which blocks adenosine or whatever. It's not a stimulant. But when you're when you're awake, it helps keep you awake.
Yeah.
And when you're asleep, it also, to a lesser degree, helps keep you asleep. And so that's why people with some types, especially narcolepsy type
Narcolepsy
1. Sort of the main
yeah.
narcolepsy is essentially an orexin deficiency. And that's how it was discovered, actually. It was in the narcoleptic dogs at Stanford, where they isolated that gene and like, well, what does this protein do? Well, it turns out that that's what it is. In humans, it's a little more complicated, but still, people who lack orexin develop narcolepsy.
Mm-hmm.
And so what these drugs do is they block orexin. So you should be asking yourself, wait, you just said lacking orexin means narcolepsy and these drugs block it. So do they give you narcolepsy? I'm like, well, short term, nobody wants narcolepsy except except people with insomnia might like a little bit of narcolepsy around bedtime.
Yep.
And so that's essentially what these drugs do.
Yep.
They sort of give you a little bit of narcolepsy for a few hours. And so they don't make you sleepy. Remember, they're blocking orexin, which stabilizes your wakefulness. It doesn't drive sleep. They're not sedating in that way. Yeah. They don't make you sleepy. So patients don't always like it because they can't really feel it making them tired. What it does is it opens the door for sleep to occur. And it lets your wakefulness fall away. It weakens your wake drive without necessarily doing too much to strengthen your sleep drive, as opposed to the other sleep sedating medications, which don't do much to your wake drive, maybe suppress it a little bit, but if anything, they're boosting the sleep drive.
Yeah.
They're trying to overpower wakefulness with more sleep drive. As opposed to the doors, what they're doing is they're letting your natural sleep drive do its thing and get the wakefulness out of the way. And so the data on them is actually quite good. They seem to be much safer long term. But again, patients don't really love them because they don't, for various reasons. Some of them, the side effects are different. You can still get some daytime grogginess if your wakefulness isn't able to be, if it's lasting into the morning and you're still having trouble maintaining wakefulness when you're trying to be awake.
Sleepwalking.
But then that's the other thing too, where other stuff comes with narcolepsy. And so sometimes people get symptoms that look kind of like narcolepsy, and they can sometimes be difficult to tolerate for some people. And they just don't like it. But from a sleep perspective, it seems to be safer, especially if you look at the clinical trials. A lot of these drugs have been focusing their clinical trials in older adults because if there's one group of people you do not want to give a medication to that's going to increase memory problems, increase falls slow down reaction time, and create brain fog, it's adults. People who are like over 50, over 60. Because it does massively increase fall risk, and that can be very debilitating. So,
the way I always look at it, sorry to interrupt, the way I always look at it is these things can be combined with behavioral treatments for insomnia.
Oh, totally.
CBT. So you want to see someone, ideally, if you're on medication, who is knowledgeable about this area. And it's about, if you have to be on medication for some reason, it's about combining it with CBTI or ACT or something else
it's
to
not
get in the
supposed
lowest
to be a competition.
Dose. Exactly.
Like with depression, nobody says, oh, don't get therapy, take medication. Therapy sucks. It takes too long. I mean, people do say that, but no one says that like it's one or the other, or no one says, oh, forget medications. Therapy is what works.
Yeah.
No, with depression, it's about combination. And honestly, to be totally honest, in a perfect world, people would show up to the insomnia clinic never having been on any sleep medications, and then we'll do what we do and it'll be fine. And everyone would look like they look like in the clinical trials. But the reality doesn't work that way. Ever. It's unusual for someone to show up in my clinic who's not already on medication. So having it be a combination therapy is not an option. It's sort of necessity.
So when it comes to treatment for insomnia or insomnia in general, what's something you wish, just briefly, that people knew more of or knew about?
I wish that people knew how much potential there is to fix their sleep problems in a relatively short amount of time. People come in with sleep. People say like, oh my gosh, I've been struggling this for 10 years, for 20 years. How long is it going to take to fix? I'm like, it'll take a couple months, and then you're going to be feeling way better. Like, often people say, I wish I did this sooner. Like, that's what I wish people knew. I wish people knew how programmable their sleep actually was. That with a little bit of help, that we can actually make an impact in a meaningful way. I mean, we're just lucky we're in the sleep world because we have a therapy that actually works. and
Wow.
works for a lot of people. And even when it doesn't work, there's other things we can do. It is extremely unusual for someone to come into my clinic and leave not feeling at least significantly better. If not, maybe my sleep's not perfect, but it's not near the top of the list of the things that I worry about in my life anymore. Like, it's unusual that doesn't happen. And I wish more people knew that they don't have to be fighting this fight and struggling.
So Michael, we always like to end with something to sleep on. One last point for anyone looking to change their sleep habits. So when it comes to treatments for insomnia, do you have any final little quick thoughts, something for them to sleep on?
So something for people to sleep on. I would say, I'll end with a little bit of an anecdote. So I get this one from Don Posner, who's another one of the leaders in the field in terms of teaching people how to do CBTI, not just doing CBTI. One of the greatest teachers, and I've seen him do this when he teaching a room full of clinicians how to do CBTI, and talking about effort, and he'll say, all right, who in this room sleeps great? So there's usually someone who like embarrassingly raises their hand, and they say, okay, when you go to bed, you close your eyes, you put your head on your pillow, what do you do to fall asleep? And they always, and every time I've seen him do this, it's always the same answer that the person says. What the person says is, and then he says, exactly, nothing. You don't do anything. Yep. When people sleep well, they don't do anything. Yep. And the goal isn't to figure out all the stuff you need to do to sleep well. The goal of therapy is to not need to do anything.
Thank you.
And I think sometimes people need to be reminded it's not about what you do. Sometimes more is less. And sometimes it's about learning how not to do that clears the path. Anyway, so that's the last thought to end on.
Well, Michael, thank you so much for being here. I've greatly enjoyed this deep dive discussion that, as I said, we could talk about all day long.
Yes.
But thank you. And I really do think that this is going to be a great resource for people who are interested in learning more about insomnia. So thank you again for being here.
Yeah. Like, it's a message of hope. You know, there's probably something that can be done.
Great way to end it. Thank you so much.
Thank you. Thank you.
Thanks for listening to Sleep Talkin' with Dr. Shelby, a Sleepopolis original podcast, produced by Ready Freddy Media. Remember, if you're tired of hitting snooze, hit subscribe or follow right now in YouTube, Apple Podcasts, Spotify, or wherever you're listening. And for even more sleep tips, visit sleepopolis.com and my Instagram page @SleepDocShelby. Until next time, sleep well.